All right. Hello, everyone. Welcome to our webinar of the Partnership for a Lead-Free Future on a preview to a new blood lead level interactive database for low and middle income countries, also with data from other countries, upper middle income countries, etc. My name is Angela Bandemir. I'm forgetting to record, so I'm going to do that right now. Hang on a second. I am recording. Okay. So I'll start again. Thank you very much. Welcome everyone to our webinar today. Good morning, good afternoon, good evening. This is a technical webinar to preview new blood lead level interactive database for low and middle income countries, also with data from other countries as well. I am Angela Bandemir. I'm the Senior Technical Advisor to the Partnership for a Lead-Free Future. I will be moderating today, and I will also be presenting in the session today. The session is going to be recorded and available on our website at leadfreefuture.org. Feel free to introduce yourselves in chat if you like, including your organization and country where your organization is located. This morning, I'm going to go over the agenda briefly. We're doing welcome and introductions. We have a presentation on the context, lead exposure in low and middle income countries where this data tool fits in, the overview of the development of the data tool, a demonstration of the data tool, then we'll have an interactive feedback session and we'll wrap up. I would ask that you hold questions until that session as I'll be busy moderating and following the slides, but please do feel free to put questions in chat and we'll address them when we get to the feedback session. Our speakers today are myself, again, technical advisor for the Partnership for a Lead-Free Future, spent many years at the U.S. Environmental Protection Agency working on this issue, helped create the Partnership for a Lead-Free Future, and now I'm here today. And I'm also joined by Emily Nash, who is an environmental health specialist at the United Nations Children's Fund, who will be speaking to you about the data tool today. So a little bit on the background of where this data tool fits in. For those of you not familiar with the database or with the Partnership for a Lead-Free Future, I wanted to introduce you to the partnership. We are a global partnership of many different partners from all stakeholder sectors, industry, government, and civil society. We were launched in 2024. Our goal is to end childhood lead poisoning by 2040. And we have more than 90 partners with over 40 countries who have joined us. Blood leads level data underpins what we know about the risk of lead poisoning globally. Blood lead data is used to predict health effects, loss of IQ, and thus can also calculate education decrements. Lead is estimated to contribute to about 20% of the education difference between upper and lower middle income countries, and the economic impact is quite high of almost 8.3% of GDP in low and middle income countries. Blood lead level data is available for all countries as modeled data for many countries by the Global Burden of Disease. And you can see from this map, the darker the level, the higher above 5 microgram per deciliter children are. And so it can be seen that blood lead data is a very important data point for understanding childhood lead poisoning. The background on the tool is that the tool was originally, the data were collated by UNICEF, and they are graciously being given to the partnership as a whole to be put on the Partnership for a Lead-Free Future website, where we will host and also continue to update it. It's not publicly available yet. This is a preview session to show you its functionality and to obtain input from you on other functionality that might be helpful to you. And then when it is available, we will let everyone know. It will be available on our resource library at the link here on the page. And so we look forward to hearing your input today. Again, back to the data gap, the blood lead levels can be a very important piece to a country developing a plan towards addressing childhood lead poisoning. This graph here is from the Partnership for Lead-Free Future Global Framework to End Childhood Lead Poisoning, and it's one of several indicators of progress towards childhood lead poisoning reduction. So we're looking to hopefully have more countries with blood lead level data, ideally nationally representative, and countries that also are conducting this type of screening on a routine or periodic basis. So now I'm going to turn to Emily, who's going to give you a little more information about where the data came from and how it was developed. Emily?
Thank you so much, Angela. Good morning, good afternoon, good evening to everyone. As Angela mentioned, I work with the UNICEF Healthy Environments for Healthy Children team, which covers lead poisoning, as well as other heavy metal exposures, and then a range of children's environmental health topics like air pollution and climate and health. So I'll be speaking primarily about our focus on lead poisoning at the moment, and talking a little bit about how this database and the tool came about. It's been a long time in the making through different iterations. So as Angela mentioned, we rely a lot on blood lead data, both to understand the severity of the issue in any given country and also to track progress. And when this initiative was first starting, the idea of this systematic review of all available blood lead data in LMICs that meets certain criteria was originated by Brett Erickson. And the idea was to really see what was in the literature, because otherwise the available sources were really, as Angela mentioned, the modeled data through the Institute for Health Metrics and Evaluation, which is an incredible resource in itself. And in 2019, as we were starting this, in particular, there were a couple of factors that made us want to look at the kind of on the ground validated blood lead data that were coming out from countries. And those two factors, one is that the phase out of leaded gasoline. So that was a huge driver of blood lead levels throughout the decades. And as that was being curbed, we really wanted to see what kind of the remaining blood lead burden was in the influencing sources. And around that same time as well, we were really starting to understand how diverse the exposure sources were in a lot of these countries. Like, for example, I think of adulterated turmeric in South Asia, for example. We were really starting to understand just how significant these sources outside of gasoline and lead paint potentially were. So that sparked our interest in the systematic review. So this was originally conducted in November 2019, and I've linked to one of the publications that came out of it. And as I mentioned, it was a systematic review of published literature with a focus on LMICs. So we essentially searched PubMed for every single country individually within the LMIC categories from the World Bank, and tried to find any blood lead data. We focused on published data that we started with papers from 2010, and we really were interested, as I mentioned, in the actual data being collected in more recent histories to try to understand the remaining burden after the phase out of gasoline, which obviously happened at different times in different countries, but that was just a criteria that we enacted in order to try to capture that. We focused on larger studies. So we looked at only studies that had more than 30 subjects, and we limited it to whole blood. So anything that involved serum or plasma, for example, we didn't include. And a significant limitation is that we looked at papers in English only. And then we also undertook a bias assessment for each of those papers because we were concerned in part about the quality or the objectivity of some of these papers. So we had a system for assessing that. Next slide, please. And then since that was an original data set, as I mentioned, that a paper was published around that. And that paper actually pooled some of the data that we pulled to try to come up with, to compile data from within the same country. And then a subsequent research effort occurred in 2022 between Brett Erickson and Mary Jean Brown, which was published last year. And this was to re-examine countries where we previously had not found eligible papers. And this focused just on kids under on kids, so individuals under 18. And again, with this bound about the leaded petrol phase out, and also included a bias assessment. And then the most recent additions have come from UNICEF, and it picked up essentially where the previous papers left off, again with this focus on children only.
Great. Thank you, Emily, for that overview of where the data came from so far. Now I'm going to share my screen, but before I do that, I'm going to see if there's any questions. If you'd like to raise your hand, I can allow you to talk, or you can put a question into the Q&A or chat or whatever you're able to access at this point. Any questions what we've said so far? I don't see any questions at this point, so I'll continue with the demonstration and then we'll go to the Q&A after that. So let me, oh, I see there is one question. So did the data collection capture the methodology used? Would you like to answer that, Emily?
Oh, sorry, I don't know if I'm seeing the...
It's in the Q&A. The question is, did the data collection capture the methodology used?
Sure, yeah. So I think when we show the full data set, it'll give a better sense. But yes, we always captured the technology that was used to measure the blood. So whether it was like a point of care lead care or ICP-MS. So that's all there. The more of the design of the study itself, we did separate out whether the population would be considered a background population or a particularly at-risk population. And that I think was very important because at the time, a lot of the data that we were seeing was pulled just from hotspots. So for example, around a lead smelter, and the information on more of a larger percent of the population or kind of a control group was more limited. So we did divide all of that out to try to understand this background level versus, we debated the terminology quite a bit. I believe in the database it's elevated. So yeah, we did capture elements of the design of the study.
Okay, great. We have another question in the Q&A about what tool was used to assess bias.
Yeah, that came from it's a U.S. Department of Health and Human Services tool. It's OHAT, which I can remember I would have to remind myself of exactly what that stands for, but essentially it's out of the U.S. Health system. It's a validated series of questions to understand potential biases and level of confidence in a certain paper. I can put the link in the chat.
Yeah, if you would do that, that'd be great. And then there's another question about background versus at risk. Are there any other metadata? I think what I should do now is probably just demonstrate the tool and see if this answers your questions. And then we can go back to that in the feedback session. So why don't I share my screen? and show you the tool. Hang on a second. All right. Are you able to see it? Oops, no, I need to stop that share. Sorry. Let's try again. There we go. All right, so this is the tool. It's currently on an internal database at UNICEF. We're transferring it over to the PLF website at this point. It'll be in a slightly different database, but same functionality. So the main sort of idea of this is that the studies can be found by country. If you click here on the left in this list, you can see a bunch of countries here, and you can click on the one that you would like to look at. I'm going to start with Indonesia just to show you the functionality of the database, and then I can also click on some other countries just for interest. So if you click on Indonesia, the map will hone in on Indonesia and show Indonesia on the map. And you can see here there are search parameters, and you can search by these different parameters. Currently, the only ones that are there, we could do more, are background or elevated. So as Emily was describing, the attempt to try and differentiate between sort of hotspot and very high level versus sort of more chronic and general exposure was made. And then also the gender, female or both. And then when you scroll down here for Indonesia, you'll see there's a list of studies. I'd say about 8 or so studies. They're all listed here. So the country would be in this column. Then there's the title of the study, a link to the abstract of the study, and what region it was done in, the sample size, whether adult or children, whether this is the background or elevated, and then there's a bunch of statistical information, the arithmetic mean of the blood lead, and microgram per deciliter, standard deviation, and others, geometric, etc., to help you understand the shape of the curve. And then the age, and then the type of blood draw. We did ask about methodology and the analysis method. So you can see all that is here summarized and taken out of the paper. If you clicked on this link, I'm not going to do it now because it's going to have me validate, but I had clicked on it ahead of time, and it would have taken you to this paper. So it clicks right into the paper itself. So if you wanted to check other parameters, other information, other authors, etc., it's all in the paper here. So I'll show you a couple of other countries. So we just around the world, we'll go over to Russia, for example. So it's not just low and middle income countries in this database. Russia is not considered an LMIC in the World Bank definition. And so the number of studies here is also around 8 or so. And you can see there's various different analysis methods. These are mostly venous studies, and the analysis methods are indicated here on the side, and the locations, etc. Then we'll go to over to Africa. Click on Uganda. And again, here are the studies. You can see here mainly venous. There are some lead care, some capillary studies there. And then over to Colombia. Where again you can see the various studies in Colombia. Again, we have venous, gas, AAAS studies here. So that's the functionality of the database. It's really quite simple. It's really an access to all the papers, and as Emily was saying, it's curated where there are criteria that were used to pull these together, certain types of studies and certain rigor of the studies. So it's valuable in that sense that it removes the need to search yourself for a certain quality of study. It's all here in the database. So I'm going to stop share and go back to my other screen where we can have a interactive feedback discussion here.
Angela, would you like me to show the background data as well, and because that will be
Yes,
publicly
actually,
available?
Emily, if you want to show a use case study, that would be great. Why
Sure,
don't
I'll
you?
just share my screen here.
And I'm looking in the Q&A while you're doing that, and there's a question about survey year. I didn't see survey year. That would be an interesting thing to consider adding.
Yeah, I'm trying. Is my screen visible now? Is that clear to
Yes,
her?
it
Great.
is.
So this is the raw file behind that dashboard, and this will also be publicly available. So in terms of question of the year, we can see if that is captured. Looks like that's not pulled out here either, which would be a great thing to
Yeah.
include. So I just wanted to show it in terms of the discussion of what else may be valuable to pull out, or what could be changed moving forward to make it more useful. So I just wanted to show a little bit more of the back end. So similar to the dashboard itself, we have all of the relevant titles. I pulled up Egypt just as a point of discussion, and just to show a little bit more of what is actually pulled out. So we have the full citations for the papers, of course, and the link to the abstract, as Angela highlighted. But then we also see more of how we divided out different groups, even within the same study. So, as I mentioned, as we were looking, we saw, a lot of information on hotspots, but maybe not as much on the background. And so, in a given paper, for example, if there was a study of battery workers in a given country, and then also a control group, we separated those out. And that is described here in more detail in the back end of the data. So, for example, this is a control group out of this paper. And I'm sure if we saw somewhere in here, we would see an exposed group as well. The region and city, which is in the dashboard, as you saw, all of the stats. And then this background and elevated. And then the one other part I wanted to highlight was this lead exposure source. So if it was an elevated group, for example, what was the identified or suspected source? If that was indicated in the paper, that wasn't something that we independently tried to sort out. If it was highlighted as a factor in the original publication, we pulled it here. And in terms of use cases, a couple of the things that we've turned to this data set for. One is if you're designing a study, for example, we still, I think, are very much in search of very good nationally representative data. And looking at, for example, the background levels in a given country could start to give us a sense of a starting point for a study design, for example, like what is the potential anticipated prevalence in that country as we're designing the study and thinking about sample size. It also would give us information on particular regions or cities that have been identified as having elevated levels or different occupational groups. So with this Egypt data set, for example, we see battery manufacture and recycling, which we would expect. But there's also ceramics, a ceramics group, which and tobacco products. So thinking about different risk factors in a particular um, country or regional um, setting, I think could be very useful. And just to give an oversight of what is currently available if you're kind of coming into the space as an implementer, and just understanding what's already been done, and where the gaps are as well.
Thank you, Emily. And I think we also had at least one country where you had broken out occupational exposure as well.
Yes, yeah, we would see that. I'm trying to think. Yeah, where is that? There we go. Occupational. Thank you, Angela. Yes, you can also filter just to say we want to look at only occupational exposures. So here we would see the different, so folks that work in dump sites, the ceramic smelting, automobile repair. So yeah, it's a helpful feature as well.
Yeah. And as you were speaking, we did get some more questions in. One is about whether there's an indication of the underlying data being publicly available. Is that something you determined while you were looking through the papers, or would that be something that the um, person wanting the data would have to find out themselves from the authors?
Yeah, we only link to the abstract. So I think anything beyond that would need to be looked at separately, I would say. Yeah.
And then there's another question about inclusion criteria. And I think you talked about this a little bit, but there's a specific question about how the um, the studies compare with IHME or similar databases, WHO or IHME, and what is the difference?
Yeah, it's a great question. We we're starting to understand that picture a little more. I would say that um, we have seen pretty large differences in certain countries between um, the estimates that come out of um, so I mentioned that original paper that we pooled the different for any given country. If we could, we pooled the available information for the background population, for example. And there were a lot of differences with IHME. So, but we also then have seen when an actual truly representative study has been done in a country, it also doesn't always match our estimates. So it's kind of different looking at the real value from different angles. And I think really, obviously, the gold standard would be something like a truly nationally representative study. We've started integrating the results of the UNICEF mix studies, the multi-indicator cluster studies, where lead has been included. Those I think would be a valuable contribution here as well, for kind of a truly representative estimate.
Yeah, and this is what the Secretariat hopes to be able to do is to add studies as they're completed, so they can be part of the database. We have another question about it's actually a comment about background versus elevated as categories, and perhaps considering population-based versus exposure-focused, or even splitting into three categories: population-based, community-based, and exposure-focused.
Yeah, I think that's a great suggestion. I think the representativeness is something that's not well captured currently. And frankly, at the time in 2019, there essentially wasn't any kind of fully representative data, or at least not widely available in LMICs. So I think that's a great suggestion. These control populations are informative, but certainly shouldn't be taken as a truly representative figure. Yeah, I like that idea a lot.
Great, thank you. We have another question about the mixed studies, since we mentioned those, about whether they're published by countries usually. And I think what you didn't indicate, but I think what would happen is you would include whatever the government publishes. That data would be the official government data
Yeah,
or link
absolutely.
to the
This
publication.
right. It would pull from final reports, publicly available final reports out of those studies. Yeah.
There's a question about including a column of percent above 5 or 10 micrograms per deciliter. Also may be helpful to know if a laboratory is used, whether it's local or international. Um, I think it would be possible to do if that's included in the study. I don't know if studies usually indicate exactly which labs they've used. Maybe some do, some don't. But we could see if that data would exist. I think what we're trying to do is be able to pull whatever is based on published data. So not wanting to necessarily have to track down the authors and find all that information out. That would be too resource intensive for us. Um, but it is certainly something to think about if it were available in the published report.
Yeah, and the first question about the percent above 5, for example, um, that I think again, if that, yeah, as you mentioned, Angela, if that's available, I think um, I'll have to remind myself if it is in the published paper from 2021. But when we pooled the data, there was also an effort to try to quantify um, the percent above just based on the distribution from the statistics shown. So if we knew um, the mean and median and some of the IQR, for example, I think there was an effort to translate that into percentages above certain thresholds, but that's often not reported in these papers themselves.
There's another question about studies that only report geometric means. What do you do with those? Have you had that experience, or are those studies you don't tend to include in your list?
They would have been included, I believe. I think uh, we included whatever central measure was reported. Um, with the pooling of the data in that 2021 paper, there was a process for trying to kind of standardize things a little bit. And the primary author, Brett Erickson, would have kind of more insight there. If there are specific questions, I'm happy to direct them.
A question about a process by which researchers can submit their work for consideration of the database. If so, will there be parameters? Um, so that is a good question. I think this is part of what we're um, looking for input on, and the Secretariat will be conducting that process moving forward. So there isn't yet a process that's been designed. I think we're going to have to look at what's resource possible and what types of studies are the most helpful to the community. So we'll be designing that and possibly reaching out to some of you for help in that. So at this point, I would say if you have any questions and would like to include a study, feel free to reach out to me. I'll have my email at the end, and we can talk about that. I'm also able to unmute folks if the webinar automatically muted everyone. So if you'd like to raise your hand, you're also able to speak and share your thoughts as well, or continue to share questions in the chat. This was a really good discussion so far. And I can put the link to the bias tool in chat.
Yeah, thank you, Angela. I don't seem to have access
No
to
problem. I don't know that people have access to chat, unfortunately. Let me see if you do. So I put the link to the bias tool from the NIHS website into the chat, and it'll be included in the notes for this meeting as well. Any other questions, thoughts? We have a little bit more time. If someone wanted to see a particular country, we could see that it's there. Okay, we've got more questions coming in. So a question about capturing if a process of confirming blood lead levels was part of the data collection. The process of confirming blood lead levels was part of the data collection. I'm not sure.
Yes, I think it sounds like if we looked at what quality control was done, I would, I mean, I'd have to look back exactly at the bias criteria, but I don't think we had a specific criteria of, if it was lead care, was there a venous confirmation, for example? I don't think we went into that level of detail. If there were concerns about the method used or if the results seemed, sort of on the wrong order of magnitude, for example, that definitely would have sparked our scrutiny with the review.
Then, okay, sorry, the chat's disabled, everyone. I apologize that. I will send an email to all participants with the notes and the information from this. To see if I can put it in the Q&A, but I'm not sure I'm able to. So apologies for that, but I will share it. All right, anything else? Are units listed specifically? So microgram per deciliter is listed. Any other units that would be listed?
Everything would have been converted to micrograms per deciliter. So if it was reported in micrograms per liter, for example, or I think there were some where it was in nanomoles, for example. So everything was translated into a common unit.
Great, thank you. Any other questions? And if you think of things, I'll share my screen again so you can see my email. Please do feel free to reach out to me, or if you'd like to contact Emily, I'm happy to put you in touch with Emily. We have another question. Are suspected exposure sources listed categorically? So in the visible data, you can see that all that detail is not included in the actual visible tool, but in the background data set, that is included. And I believe you said, Emily, that UNICEF could provide that to anyone who would like it. I think we would continue that practice as we take up this database. So you could get access to the information through the detailed database, Excel spreadsheet. Another comment, it's important to look into the type of test, such as lead care versus venous, because lead care is censored data due to its low detection limit. Yes, you saw there's a column that shows what method was used, and so you can decide, if that is data that you would want to accept. You can check in the paper to see if there's, as Emily said, any venous confirmations done for it, to see if that's data that you would want to be using. But yes, that is a very important thing to look at. The database is available currently on the UNICEF internal SharePoint site. And for those who joined a bit later, PLF will be putting it on its public knowledge library sometime this summer, so it'll be publicly available. We're using this input to help us maybe improve the interaction of the database. And we'll be notifying everybody when it's available and possibly turning to some of you for, further input. If we had questions about your comment, we'll turn to you for more detail if needed, and hopefully we can create this to be something that's useful. So the dashboard, unfortunately, not yet publicly available, so I'm not able to share the link to it at this point. This was a preview session. If you have further questions about it or wanted me to show you more on it, you're welcome to contact me directly, and I'm happy to do that for you. There's another comment here talking about recommending looking into children living in proximity to lead mines. Yes, if there's studies on that, we would certainly include them if they meet our criteria. And I think there are a few. I'm thinking for countries like Zambia and other countries with mines. There are many countries with mines, Indonesia and others. I think there are studies about children's blood levels in proximity to mines.
Just as a preview, Angela, I can share. So I've sorted
Sure.
let's see. In that, I think there was a question about how kind of categorized the exposure source column is, but I just looked up mining and we can see that so this is for all geographies. And then as Angela was saying, if we're interested in children, we could filter here again. And then we could see, just to get a sense of what countries we're talking about, then you can see quite a wide range geographically of exposure groups that have been looked at in that. Yeah, so just to show what all that is available there.
Thank you. So again, I don't think I was sharing my screen. I'm going to share my screen just to show my email again, so you can see it. Can you see my screen? Oh, now we are. Here we go. I'm available at that email there. If you have any other questions, I see another one has come in on the interquartile range, saw low and high. If possible, show whether it's 75th, 90th, or 95th percentiles. Are papers consistent in how they report IQRs? Could that be
Yeah,
done?
it's a good question. Our solution to that was to just capture essentially whatever was there. So we have 95th, we have 25th, we have 75th, and each paper, whatever is reported, we captured some standard deviation, for example. So I think those become, if there is a motivation to pool the data or to look at it a little bit more aggregated, I think those statistics come into play more. But I think for just sort of a database of available information, our solution was just to report whatever.
Yeah, again, we're trying to capture what's in the literature, and I think drilling down further may be a bit resource prohibitive in terms of what we're able to then capture and easily put into a database. But we've taken note of that. But IQRs are, dependent on the data, specific data sets. So great. I think we're winding down here. If people think of any other questions, I did put my email. Thank you. I did put my email in the Q&A session. So if you're able to look at the Q&A, I did respond to one participant who sent their email to me, and those of you who have registered, I do have your email. So, and you will all be receiving the meeting recording link and the information from this meeting. So I think if there's no other questions, we can wrap up our conversation for today. Thank you all for attending. It was really great to have your input today. Look forward to being in touch and for having this on our website shortly. Thanks, Emily, for being here, and thanks everyone else. Thank you so much.
Thank you.
Bye.